This guest is very special to me in so many different ways. And the reason why is Dr. John Mansour is actually my little brother in dental school. And it was one of those things where when I was a second year, they introduced me to John, and we've been very good friends ever since. He's somebody that I look up to in so many different ways, somebody that I consider a brother, who has helped me out. And it's been an amazing journey that we've been together and seeing each other grow in so many different ways. As I mentioned, John obtained his DDS from the University of Detroit Mercy in 2012. He then wanted to go ahead and do a little bit more. So he decided to complete a specialty program in dental anesthesiology at Lutheran Medical Center in Brooklyn, New York. And then after that, he sat down, we talked a little bit, and he decided that he wants to even do some more schooling. So from there, he went ahead and he entered a specialty training program in pediatric dentistry at Mount Sinai Hospital in New York City. Now, for those who don't know, Dr. Mansour is actually a US citizen. You know what? He liked me so much that he said, you know what, Hisham, I'm just going to move to Canada so we can work together. Yeah, not the full story, but that's how I'd like to believe anyways. Close enough, right? Yeah. He enjoys many perks of treating children, including discussing favorite cartoons, cartoon characters, and finding creative ways to make dentistry as fun as possible. And I can vouch for Dr. Mansour. Everybody that I send to him comes back to me saying that he's absolutely incredible and he's an absolute joy to have, and he's a treasure for the pediatric industry. He currently practices in Guelph, Hamilton, and London, Ontario. So without further ado, my brother, my colleague, my friend, Dr. John Mansour.
Well, thank you, Shem. That's a great introduction. Obviously, we have a bit of history together, since I feel like I've known you all my dental career. Thanks to Dentistry Academy for putting on these webinars. Obviously, they've been a great constructive way of using our time right now, especially since we can't practice. I'm glad I can add a few things, hopefully a few pearls to the new grads that are graduating, or the fresh grads for their careers. Starting this lecture off, it was a little tricky for me to kind of know what to talk about. I did reach out to some of the fresher grads and I asked them, what do you want, did you wish you know, or what do you want to know right now in terms of pediatric dentistry? And I got a variety of answers. It was more of an informal survey, but I used those answers to kind of create the content for this. And it's going to be very broad and not in depth. So if you are interested in more of these topics, let me know. I can help guide you in the proper direction for that. But let me start by why pediatric dentistry is kind of important for your practice as a general practitioner. It's a great practice builder. One of the things our friend Vic Jindal always says is, what's a patient worth to you? And if you are starting out early, or you're building your practice and just started out, and you have some time on your schedule, and that little kid, let's say little Billy, has a toothache and can't find anybody to see them right now because every pediatric dentist is booked for 3 months, you become the hero then. You get to give them a little peace of mind. It could be as simple as giving them a prescription or throwing out a temporary filling, and you just became a hero. And usually what happens with me is, with these emergency patients, when we are able to squeeze them in, is the parents ask us, hey, do you guys take adults here? And I wish I did. I'm a pediatric dentist, but we don't. And for you guys, I can only assume that that's a great practice builder for you guys. And other things for you guys to consider: establishing that dentist-patient relationship early. We like to talk about a dental home from the American Academy of Pediatric Dentistry. And when should you see a kid? It's 6 months after their first tooth comes in, or 1 year of age. And one of those things what you shouldn't do as a general dentist is you shouldn't say, oh no, they don't need to be seen until 3. The reason for that is kind of takes away how essential dentistry is to the overall health. And 2 is, if the child ends up with caries later on and the mom says, well, you told me they don't need to be seen until 3 or 4 years old, that's not a good look for you. So what I would say at that point is, if you're uncomfortable seeing that child early on, I mean, I've seen a 1-day-old with neonatal teeth, and I see them usually up to 16, sometimes even older. But there are resources that you can guide the parent to. For example, go see a pediatric dentist. And that first visit isn't meant to be like, a full-on exam where you're going to count teeth, because usually they don't have very many teeth. It's usually more an educational visit for the parent. And you can have one of your staff members do most of it, and for you to just walk in and actually do the exam really quick and kind of go over that. It kind of builds that relationship and shows importance to that visit. And then the other thing is, it develops the trust. you see this kid at the age of 1, and then as they go on through their lives, you're their dentist. How many patients that you can think of, oh, well, I drive 45 minutes an hour because I really like my dentist back home. Well, you're going to be that person. And if you're developing that trust early on, you're building your practices throughout your career. And it's a great way, like I said, to bring in not just that one patient for an emergency, but usually the whole family likes to come in. By far, the most popular topic people wanted to know about was dental trauma. And unfortunately, over these past few weeks with COVID, I've seen an uptick where I practice with dental trauma. I think children are staying home and finding creative ways to knock their teeth into things. I've seen a lot of this, and I can understand why there's a lot of confusion about it. Now, I can sit here and spend 7 hours talking to you guys about dental trauma, and the reality is that you probably won't see one for a good long time, and then you'll forget everything I've said. So what I'd rather do is give you guys resources that you can look up on your own when you need it, so you can have access to this information. And the best resource I can give you is the International Association of Dental Traumatology. They have 3 fantastic resources. The first one is the Tooth SOS app, which you can download on your phone. I literally tell all my parents that come to my office, download the app. It's meant for parents. The free section is for parents. But as a provider, you can probably use that free section yourself and kind of have a pretty good idea of what you need to do. There is a paid subscription that you can get for the professional section if you really want to, but the free section is more than enough to kind of guide you. They do have a PDF document, and there's the link at the bottom, and Dr. Shurgan's going to post it in the chat. That is a PDF document that kind of sets a bunch of guidelines into different types of injuries for all types of teeth, and it's a great resource to have if you want to download it onto your computer at work. But by far, my favorite resource is Dental Trauma Guide, and it's also from this same organization. I'll kind of walk you guys through it. Basically, you can go into Google and type in Dental Trauma Guide, or just go to the website, dentaltraumaguide.org. Now, there is a paid version of this website if you really want to. It's $35 a year, and if you have a lot of dentists in one group, you can get it a little cheaper. The paid resource is different than this resource because it actually asks you the questions and you fill in the bubbles, and it takes you to the proper section. With the free resource they have here, it's right in the middle of the page. If you look right here, it's highlighted in blue. Let's pretend we just had a patient come in, they're 9 years old and just had an avulsion. Well, if you click on this little icon here, this comes up. And then, for example, let's pretend, and we know it's a permanent tooth. Let's say it's a 1-1. You click on that, and you get this. And it's going to list all the injuries that are associated with a permanent tooth. In this case, it's an avulsion. We're going to click on avulsion, and it gets you this document. And I'm sorry I couldn't fit it on one slide, but this is one continuous document, starting with first aid, talking about a closed apex versus an open apex, how long has a tooth been out of the mouth, and all these things that are useful information to you right at the time. Like I said, this is the best resource I can offer in terms of dental trauma, and it's a really nice thing to have. You can even bookmark this on your browsers at work or on at your ops. That way you can quickly access this information. The second most popular topic, and everybody kind of was asking about behavior management and tips and tricks and how to be better with dealing with children. And I wish there was a magic formula. I mean, sometimes it takes 2 to 3 years in a residency to figure all this out, and I'm still learning how to manage children and trying to find creative ways of helping them out. But the main misconception about behavior management is that we're taking all these negative emotions, and these are from the movie Inside Out. If you haven't watched it, great movie recommendation. And we're basically trying to focus on making the child happy. But that's, I feel like it's more of not a realistic situation. The reality of it is all these emotions play a factor, and you have to learn how to deal with all of them collectively, and hopefully you can have a child walk out happy. Now, I've had children start out happy and leave unhappy, but the treatment got done and the parents happy. And I've had vice versa, where they start out unhappy and walk out of the office very happy, realizing how they accomplished something. So it's a very dynamic continuum that we're always managing. Sometimes in the middle of the procedure, for no rhyme or reason, the child will become unhappy. And that's where we have to kind of manage it as we go along. I can't obviously sit here and go through every single behavior management tool, because that could take a very long time. But so I'm going to keep this to the main ones. One of the things I find helps me a lot is positive pre-visit imagery. What I mean by that is when somebody calls the front desk to schedule an appointment, I have the front desk try to give them these tips. is your child a big fan of, if you're a parent, I'm sure you know what Paw Patrol and Peppa Pig are. Um, are they big fans of those shows? There's a show that they like that has a dental episode. Those little dental episodes can be the difference between a positive visit and a bad visit. Because usually what happens is they're listening to an adult or a brother who says, oh, you're going to the dentist, well, you're going to get a needle and have your teeth out. That's not really what you want in a child's head, because that's half the battle, changing their conception about coming to the dentist just for an exam. So these little shows help out. There's plenty of games and apps out there in the digital world. And if the child's more into books, there's plenty on Amazon about that. Some providers provide their own content. Some of my colleagues even have a section on their website or a PDF pamphlet that they have every parent read. Some people go on social media and basically follow one of their patients around as they get a cleaning. It's not a bad idea to have this content just to build up the positive imagery that's related. And it's funny if you think about it, because then one of the best predictors of how a child will do in the chair is maternal anxiety. So usually when I see a mother is very anxious, who knows what she told the child at home, and usually it ends up, you know, going downhill. But I'd say that's, for me, I'm able to get around it sometimes, but it's a nice predictor for you to kind of pick up on as you're seeing these patients. Tell, show, do. I know it sounds so cheesy, and I know a lot of people say, well, it takes me a long time to do this and I don't have the time for it. To be honest with you, it doesn't have to be you. If you can train your staff to do some of these things while you're doing other things, then you walk in and you pick up and go. The key to it is having a good attitude. If you already think it's not worth your time, then it's not going to work. You have to believe in it. And the other thing is focusing on the child. When a child walks into my op, I don't really look at the parent. I focus on the child. I try to make them feel important, because this visit is about the child and not the parent. For example, a child walks in with a Spider-Man shirt on. I'm going to tell them something like, oh man, I didn't know Spider-Man was coming in to see me today. I'm so lucky. What a lucky dentist I am. And all of a sudden, that child's hiding behind the parent, comes out and wants to show you their shirt, and they want to be your friend and they trust you. You're building that bond slowly. You're not just going to have them in the chair opening up wide and being your best friend right away. You have to kind of work on that relationship for 1 minute or 2 minutes, or even have a staff member do this by the time you come on in. I always like to tell other providers, show the child the instruments, let them know what they're seeing. I call them my toys. I don't call them instruments. And I like to use child-friendly terminology. Please do not show them the local anesthetic or the needle. If you show them, you can probably guess what's going to happen. It's not going to be a favorable appointment. If you get lucky and have a child tolerate it and you have that one exception, good for you. But usually it doesn't end up in a good situation. The child-friendly terminology I have here, if you have your own, by all means use that. If you want to use some of mine, I don't mind. For example, for local anesthetic, I don't like to use bee sting because it has a negative connotation to it. So I like to tell them it's cold water. And when I'm spraying the cold water, I like to tell them that if they move, it might get all over their tongue and it does not taste so good. So do they want to taste something bad? No, obviously not. So at that point, they're willing to help you by staying very still. After we do what's called the cold water, the local anesthetic, most children tolerate it fine because it's explained in a way that they can understand and they feel like they know what's going on. These little tricks here or there do make a big difference. And when I'm doing local anesthesia, I always have a mouth prop in. It's just that's how I like it. I know some people that do it without, but for me, it gives me a bit more control in case the child becomes unhappy. And one of the best ways to get a child to kind of calm down after they start crying is actually to give them water to drink, because the physical act of swallowing the water, they have to stop crying for a second or two. And sometimes I tell them, well, here's the warm water to make the cold go away, and you won't believe what a child's imagination will do. And they'll be like, yeah, it went away. Now it feels big and funny. And that's exactly what you want. Distractions become more mainstream now, I'd say, mainly because of the technological advances that we have. I know some people that have TVs. I'm a bigger fan of tablets. I feel like they're more personalized and they're also easier to replace when they break. And you're eventually going to have one break in a pediatric dental office or malfunction. The top right of your screen, you see that mount. It's called the Molar mount from Molar Mount Media. It is a bit pricey, but it does the job pretty effectively. And you can also go on Amazon and find a bunch of those little tablet stands that clip on. You can use those in your office as well. I found them to be very effective. And to be honest with you, when I'm working with a tablet and nitrous, 65% of the time, I'd say I'm working on a typodont. They're just zoned out. They don't, like, sometimes I even ask the child, do you want me to tell you what I'm doing inside your mouth, or do you want to watch your show? And almost 90% of the time, they'd rather watch your show, so you can now focus. Virtual reality is starting to become a thing. I'm trying to get my hands on this headset that's a little lighter on the head to see how it works. But it looks like the research out of Asia is pretty favorable with it, and I think that's something that's going to be coming on along later. I like to use counting as well. Children between 2 and 5 love counting because they just learned it. So usually the highest number they like is 10. It's a very comfortable number. And let's say I tell them I'm using my power washer, which is my handpiece, I'm going to count to 10 to wash away their sugar bugs. And you can drag out that 10, you can make it as quick as you want, but it gives them a definite end. They know it's going to end when it gets that number, so they feel more in control. And believe it or not, about 75% of the time, they're so focused on helping you count that they actually forget where they are, what you're doing to their teeth. Singing also works. I know a couple of years ago, Let It Go was a huge song, and I'm sure for those parents out there that have had it ingrained into their brain, just like me, I'm a pediatric dentist, it was my bread and butter every day, but it got the job done. Whether it's a favorite song they have, or now we have stuff playing on a tablet, a song comes on, we help them sing through it, and it does work. I can vouch for it. My favorite thing to do for the older children, kind of above the age of 6, they're all into video games. I like to make the whole process a game. So what I mean by that is, for example, putting on the topical, which I like to call tooth jelly, that's level 1. Let's see if you can beat it. When you challenge them and they feel like they accomplished something, they feel a sense of accomplishment, and they want to do the next step because all of a sudden it's a game. If you make it interactive, these children typically respond very, very well. Another behavior management tip that I like to talk about is the mouth prop versus bite block. I know whether you use one or the other, it's what you're comfortable with. For me personally, I like to use the mouth prop because it's more adjustable and you can make it any size that you want. And if you are going to use these, if you're using the adult one over here that's meant for oral surgery on a 3-year-old, not only is it going to be difficult for the 3-year-old, but also difficult for you in terms of visibility, because this is going to take up probably half their mouth. So I would say make sure you have a couple of different sizes in stock just in case you need to do that. As far as the bite blocks, I know some people out there say, well, find the biggest one and just put it in there so they stay open. The problem with that I find and I run into is when you keep a child open past their limits, it's not a very fun thing. And I usually work with a rubber dam. So for me to remove it and give them a break is really tricky. Whereas with a mouth prop, I can easily decrease the opening for just a second or two, just to let them relax, for example, while we're waiting for etch to work, or while I'm waiting for my assistant to mix something. And they take a break, they're happy, then we open it back up and we can continue. So I'm a big advocate of the mouth prop, but if you use the bite block, there is nothing wrong with that. Isolation, I haven't met a pediatric dentist that doesn't like rubber dam or some form of it, including the IsoDry and Dry Shields. I'm a big rubber dam person. I think it's great. And let's talk about kind of some of the advantages that you have to it. Moisture control, we're not just talking about saliva and the tongue getting in the way. If you think about it, the air that comes out of our mouths is actually humid and has some moisture in it. So if you're doing this without a rubber dam, technically you can get some moisture into that restoration that you're trying to do, even though you think you have perfect isolation. That air could get some moisture in there and affect your bonding. Additionally, visibility and time, to me, go hand in hand. If you're not retracting the cheek, you're not retracting the tongue, you can see a lot better. You become a lot more efficient because you're not struggling against all these things. And in terms of protection, for me, I've been saved by a rubber dam a couple of times, or I've had an instrument break and I hit the rubber dam instead of go down the throat. It's a major factor, and you don't want to be that person who has to send the child to the emergency room just because something went down their throat. So it's a nice layer of protection that we have. And usually my colleagues who I get to switch to rubber dam for children, the first couple of times you are going to maybe have difficulty placing it, but I promise once you become proficient at it after 2 or 3 times, you're going to never want to go back. Another thing to keep in mind, especially with COVID upon us, is if you want to decrease aerosols, and I know there's a lot of controversy going on around that whole subject right now, this is not a bad way to kind of, for your safety, for your staff's safety, for your other patient's safety, to put a rubber dam on. I think we may see more of rubber damage in general in dentistry, but it's something that you should be doing for pediatric patients for a variety of reasons. If the child loses it in the middle, you have the rubber dam on, you can at least try to finish. You don't have to worry about them putting their tongue where it's not supposed to be. As far as dry shield or isodry, I do use them, especially when I'm doing multiple quadrants, like one half the mouth in one visit. You don't need a mouth prop, obviously, but again, it goes back to that bite block versus mouth prop issue. I find that sometimes I struggle when there's a junior size and there's a small size, and the junior's too small and the small's too big, and you're like, okay, well, what do I do here? That's why I switch to the mouth prop and the rubber dam. It's obviously has advantage of limited need for suction because your assistant's hands are freed up now, very limited suction. With both of these, also one thing I forgot to mention is when you're using dental materials, they don't exactly taste too good. Like for example, etch tastes very sour. If you're not using a rubber dam and it gets on the child's tongue, you might lose them for the appointment. Whereas if you had it on, you can not only be quicker, but you would have not got it on their tongue. Now, some people ask me, what's the difference between dry shield and iso dry? And I know there's a lot of variations of this. Dry shield is, you can sterilize it. Iso dry is one-time use. And there are some very minor differences between the two, but generally it's the same concept. Then we kind of talk about advanced behavior management. I'm sure you're all familiar with nitrous oxide or laughing gas. It's a great tool to have as a pediatric dentist. It's my bread and butter. One thing I'll mention is that the RCDSO, if you're in Ontario, recently updated their standards for sedation. And one of the things they require for anybody administering nitrous oxide is authorization. So you need a permit. You can't just get the training anymore and just go straight to giving it. Nitrous oxide, for me, it's very successful. I'd say I can get 70% of my patients through treatment with nitrous oxide. So I'm lucky in that manner. However, it's not, the perfect solution. It's a great solution, but it's not perfect. Oral sedation, I struggle with this because I think parents sometimes have this conception that oral sedation means basically sleep dentistry, and that's not what it means. One other thing is that it's less predictable than general anesthesia. You are going to get some children that don't respond very favorably to it. And there's something called angry child syndrome, where instead of getting the patient sedated, the child actually becomes way more irritable. Now, if you're in Ontario, and I don't know about other jurisdictions, you are limited to one sedative agent orally in addition to nitrous oxide. For me, in my hands, it's not very predictable. I'd rather just do nitrous oxide alone. I feel like I can at least get a similar success rate. For the times that I've used it, it's usually quick treatment, like one extraction or 2 back-to-back restorations where I know I'm not done in 20 minutes. That's usually the working time you have with midazolam, which is a nice benzodiazepine to use for kids. And again, if you are using this, please review the recent changes of the RCDSO standards for sedation just to make sure you're in compliance. Finally, we have general anesthesia. And one of the biggest things with general anesthesia, I like to sit the parent down and talk about risk versus benefit. There's a bit of controversy going on right now in terms of what is safe for a child and how does general anesthesia affect the developing brain, especially in those 3 years or under. I typically like to avoid general anesthesia on anyone under 3. And unfortunately, there was a study that came out, I don't know how long ago, that basically said it can cause learning disabilities and all these things. And then a few years later, they retracted it and came out with something else that said, well, that's not really true. And the more recent data shows us that if we're doing one short duration procedure during childhood, for example, a dental procedure is on average an hour, it's really not a big deal and it doesn't cause any major issues. But it's still a gray area. And I like to make sure the parents know these risks. In addition, obviously, there is risk of fatality, which is extremely low thanks to developments in anesthesia, but it's always something to think about when we're discussing this. Now, I usually reserve general anesthesia for the greater extent of treatment or for, like if I have a parent that even if it's a cooperative child, but they drove from 3 hours away to see me and they really don't want to keep doing that, it's a great way of doing it. But again, for me personally, for the patients that are local, I like to try with nitrous oxide first just to see that it actually works or doesn't work before we jump into general anesthesia. One thing that I get a lot of questions about is why do pediatric dentists do a lot of stainless steel crowns? One thing you have to remember with pediatric dentistry is most of the children that we see don't just have one or two restorations. They're classified as high caries risk, multiple interproximal areas that have decay, and for a variety of factors, whether it's oral hygiene, diet control, or lack of saliva, or other factors that we are unaware of at this time, this child is more prone to caries. So if I place a restoration that's a little bit bigger, or even a small restoration, the rest of the tooth is still exposed to the oral environment. Whereas a stainless steel crown or any full coverage restorations like a zirconia crown even will cover that tooth up, and that way we don't have, it's a little lower maintenance for the parent to maintain these teeth. Now, when I'm under general anesthesia, there's a reason this child's under. And like we talked about earlier, there's a risk benefit with some of these learning disabilities that potentially can or cannot happen. And again, that's still up in the air. But we like to do definitive care so the child doesn't have to come back. So if we do a stainless steel crown, the chance of this child actually coming back is very, very low. And even with my oral sedations, I like to do definitive care. And if it's a pulp where I'm not sure if it's going to hold or not, I usually tend to extract it and lean towards a space maintainer rather than just going ahead and restoring it and then later on finding out, oh wait, this abscess, we have to take it out. So what I usually tell parents is there's a reason your child's getting general anesthesia, and I don't want them to have it again. So we're going to usually plan for more definitive care. I've gotten a couple of questions in the past on webinars. What's a good behavior management resource that I can have? And this is a book that I've read. It's a decent resource. It's a bit pricey. It does have a Kindle version. If you really want to learn some more behavior management tips, this is a great resource for you to have. And I felt like I should just, put it on here in case somebody was interested in that. The next topic that kept coming up in that informal survey was silver diamine fluoride. And this is not only a hot topic in general dentistry, but also in pediatric dentistry. It got approved in Canada in 2017, I believe, around May. As you can see, it's that bottle on the left. It comes from a company called Advantage Arrest, and the only place you can get it in Canada is from Oral Science. One of the leading experts, and I give her a lot of credit for a lot of my knowledge, is Jeanette McLean-Budd. She's a pediatric dentist out of Arizona. If you were attending the ASM, or that's apparently happening virtually now, I'm not sure if she's still lecturing there, but if you do have a chance to listen to her, she's a wealth of information on silver diamine fluoride. You can learn things that I don't have time to cover here, and she's just like, when I want something, that's my resource for silver diamine fluoride. So I'm going to try to dummy this down as much as I can just due to time constraints. How does it work? Basically, it arrests caries, and the way it works is it penetrates the enamel and the dentin to create kind of like a protective sheath on the outer layer of this carious lesion. If you have deeper caries, the idea behind it is that if we starve this caries that's deeper, it's not yet near the pulp, and we stop the nutrients and the carbohydrates from getting to the caries, we may be able to arrest it. And if it's shallow, we may be able to arrest the whole lesion through a chemical reaction with silver diamine fluoride. It does turn the carious areas black, which is a major cosmetic concern. However, if you put it on healthy enamel, it does not stain at all. This bottom right picture here is one of my patients that I actually did it on. The story behind this is the mom is an OR nurse, and she, under no circumstance, wanted general anesthesia, so that she didn't want to talk about it. So the options were at the time, and I think he was 3 years old when I first saw him. He's about 5.5 now, and he's doing well. Mom's on top of it. They look like that, but she said she'd rather have them like this than out or general anesthesia. So I got the proper consent and documented it. And to her credit, the oral hygiene, she stepped it up big time, and they're still stable. It's not the greatest look, but if that's what the parents want and that's the consent they're giving, we have to, at least consider it. It can be used for sensitivity. If you're having that patient with exposed root surfaces, just make sure they don't have any carious lesions in the area. It can work like Gluma. It can kind of create a squamous layer of dentin to block the dentinal tubules, so you get less sensitivity. And in the United States, it's actually approved as an anti-sensitivity agent and used off-label for caries arrest. Whereas if you're in Canada, no, that's exactly how it's approved, for a caries arrest agent. What are some indications for it? Obviously, a child with severe early childhood caries or early childhood caries in general On the top right, when I first saw that patient, they were, I believe, just over 2 years old, or maybe just a little older. And this was a knee-to-knee exam, and it was not happening any other way. They had that small lesion, and realistically speaking, any restoration I would have put on there would not have been great. To have him go to sleep for one restoration is a bit overkill. So we discussed silver diming, and the parent was great with it. That spot has actually been restored now with a resin, and it's held up pretty well. It's just kind of delaying things until you're able to see the child. And for some children, 3 months, 6 months, a year makes a huge difference in terms of their behavior. Other areas it can be used is for hypoplastic teeth, specifically molar incisor hypomineralization. If you don't know what that is, it's basically where the tooth did not form properly as it comes in, specifically on 6-year molars. And when they come in, they look like they're bombed out teeth before they even have a chance. It works great in those situations because it decreases sensitivity, and it also gives us some tooth structure to build a restoration on if we need it. I've found it very helpful for those situations in my practice. Other indications are if you have a child with behavior or medical challenges where you're just trying to, kick the can down the road while you try to figure out what to do, whether it's referring to a pediatric dentist or waiting until the child gets older or trying to get a medical history, it's a great way of using it. Usually when I have a child that comes in with 4 quadrants worth of treatment and I really don't want things to get worse, I do try to use it as much as I can to delay, or at least arrest the decay or delay the progression until I'm able to see them. It works great in my hands when I'm going to the OR. The wait list for the OR at McMaster Children's, after COVID, it's going to easily be a year. I don't want these kids to go from these larger restorations to, okay, here we are with a pulp or maybe an extraction. It's saved me multiple times in the past 2 years where I've been able to put silver diming on, and in the OR, I'm like, hey, this is great. All I have to do now is just put a stainless steel crown on and we're good. If you have a patient with a difficult to access area, let's say you have, I don't know, at 1/7 with a facial that a restoration probably won't hold because it's an abfraction type lesion, and you just don't know what else to do, or it's difficult to isolate, this is not a bad indication for it. You just get it on and maybe every recall put it somewhere on. It does stain dark, but if it's in the back and nobody sees it, why not? It's a good solution to have. Some contraindications to it. If you have a cosmetically demanding patient, it's probably not a good idea to go through it. And usually what I do with parents, if it involves any anterior teeth, I do not place it at the consult visit. I have them go home, I have them talk to their spouse, make sure it's something they want, and then they come back and sign the consent. I rarely do it the same day because I cannot, once it goes black, you can't change it until the tooth is restored. And sometimes with your resins, it actually shows through a little bit because of translucency of the resins. Other areas where you shouldn't use it are pulp exposures or anything with irreversible pulpitis or a necrotic tooth. It can cause pulpal degeneration. That top right radiograph that you see is actually an 8.5-year-old. The story behind this is that she had seen her family dentist for a while where she had a restoration, it didn't really hold up, and then she had a couple of temporary restorations placed, and mom was not interested in any pulpotomy or extraction. She really had done her research and wanted silver diamine fluoride. I wish I had the pre-op, but it was an analog x-ray and I couldn't figure out how to scan it clearly, but it was a deep restoration and I was quite uncomfortable putting the silver diamine fluoride on, but mom was very reasonable and said, you know what, I'd rather try this, and if it needs to come out later, let's just take it out. I'm okay with that. She signed the consent, was very well informed. I did try it. You can see the radiolucency around the furcation. It did fail about 6 months later. And fortunately for us, child did wonderful. We took out that tooth. The permanent tooth actually ended up coming in a month later, so she did not need a space maintainer even. But just be careful with it when you are close to the pulp. It can cause some pulpal degeneration and you don't want to be in that situation. If a child has any sores or ulcers, it can cause a burning sensation. And in addition, when it comes together to heal, it can leave like a grayish hue, maybe even permanently. And if it's in a cosmetic area, you really don't want to have to tell the parent, hey, this was from my silver diamine fluoride. So what I typically do is I try to delay it as best as I can, but if it's a bigger lesion and I really don't have that much time, let's pretend I see an aphthous ulcer on the left side of the mouth and I'm working on the right side of the mouth. What I'll do is I'll take plenty of Vaseline and rub that aphthous ulcer with it so it doesn't stain or doesn't get on it, and then go ahead and do my silver diamine fluoride. If you have a patient in braces or orthodontics, please be very careful. I've been consulted a couple of times where providers have placed silver diamine on an occlusal surface, but it leaked over to the facial surface where a child may have had, a bracket there with a little bit of a white spot lesion. Now remember what I said, if it's a healthy tooth structure, it doesn't stain, but if there's any hypomineralization or caries, it is going to stain. So there was these black lines around these brackets, and unfortunately for us in both cases that I saw, we were able to coordinate with the orthodontist, remove the brackets, and gently do an enameloplasty and got rid of it. But please be careful with patients who have ortho and when with silver diamine, because it can stain those facial surfaces if they're hypoplastic around the brackets. The absolute contraindication of silver diamine is a silver allergy. It is very rare. It's something called argyria. Argyria is basically a patient who touches silver, is allergic to it, and then they turn this purple/gray color. It's kind of a mixture of both. It looks kind of very obvious if you have it. Fortunately, it's very rare and we haven't come across it, so I won't spend too much time on that. How to use it? This is kind of my procedure for it. I start out with Vaseline, and I use a copious amount. I even pass the vermilion border. I make sure I cover it all up. And the reason I do that is because early on when I used to use little Vaseline, some of my older children would kind of lick the area and kind of lick their lips, and then you have a brown spot on there. It does stain. If it gets on your countertop, it's going to stain brown. If it gets on your fingers and you don't have gloves on, it will stain brown. Fortunately, with whether it's on the lip, on the gingival tissue, or on your fingers, that exfoliates in 2 to 3 weeks. You can try using hydrogen peroxide to make it go away a little quicker. However, by using Vaseline all across those lips, you're trying to ensure that it doesn't get on there. I isolate the tooth with gauze and cotton rolls. Now, before COVID, I used to dry the teeth. Now what I usually do is I have the parent brush before they come in. I take a little cotton pellet or a Q-tip or maybe even sometimes gauze and dry the area really well because I don't want to use any aerosols. And then I apply it to the areas. I make sure it's really saturated. I let it sit for at least 1 minute. If the child's super happy and they're watching their tablet, I try to go for as long as 3 minutes. Afterwards, this is an optional step, but I use it. I feel that fluoride varnish afterwards not only seals it in and gives you a better result, but also it masks the taste of it. And silver diamine fluoride tastes horrible. It has a bit of ammonia in it, which does not taste very good. Whereas fluoride varnish obviously comes flavored and it kind of masks the taste a little bit. Then you need to have the patient back in about 4 weeks and you reapply it the same way you just did. And then technically the patient's supposed to come back at a regular interval. What we do know is patients who get it at a regular interval, the caries arrest is maintained. What we don't know is how often that interval should be. Is it 3 months? Is it 6 months? Is it a year? For me personally, what I do is I judge basically based on the size of the lesion, and I do a 3-month visit no matter what. If the lesion's small and if the patient's on top of oral hygiene, I don't see a lot of plaque, the gingival health is good, you know what? See you at your recall, and every recall we're going to place it. If they come in and there's Cheetos everywhere and the lesions only get, it's big already, and now we have new lesions, then you know what? I'm going to see you every 3 months. So use clinical judgment for now until we have some more definitive guidance. These are a couple of my cases that I want to show you guys. This is actually one of my favorite patients. You can kind of see that there was this little bit of silver diamine here. This was not a cavitated lesion. It was just one of those white spots, and we didn't want it to get bigger. He actually had it on all these 4 front teeth. This is after we restored them. The reason I want to show you this, if you look very carefully on this tooth number 5-2, you can kind of see the black almost translucent through. So if you are going to restore after, just try to keep that in mind. Make sure the parent's aware. On posterior teeth, obviously, if it's a stainless steel crown, you don't have to deal with this. With anterior teeth, there's zirconia crowns that can cover this up pretty well. I used resin here because I was able to do it in the chair, and he tolerated actually very nicely doing 2 at a time. This is another patient where it came in very handy. This was a patient that had a lot of medical issues, and the anesthesia department at McMaster Children's wasn't exactly very happy about having this child go to sleep if we could avoid it. It was a little bit bigger than what I would have liked for a lesion to use silver diamine on, but fortunately it worked really well, and right before COVID, I think he came back and we were able to put a stainless steel crown in the chair with him because he had grown older and become a much more cooperative patient. Another question that I got different versions of is, when do I do a pulpotomy, or when do I do an extraction? Should I do a pulp on this tooth? Should I extract this tooth? It seemed to be a very common theme in that informal survey. So I want to start kind of with what the goals of a pulpotomy are. And you basically are trying to keep this tooth fine and dandy until the new tooth comes in and you no longer need it for space maintenance. You want to also have healthy supporting tissue in the bone and the gingival tissues. You don't want to have any damage done to the permanent tooth. And also, as far as when you're doing your follow-ups on pulpotomies, you don't want to see any external resorption. If you do, then more than likely needs an extraction. We do get some internal resorption sometimes with pulpotomies, and it depends on the technique, and that's beyond the scope of this presentation. But usually with internal resorption, we just monitor it, and it's usually just tooth falls out without any issues. If you end up seeing a perforation, you start seeing a radiolucency or an infection or an abscess, that's the time to go. But I would say that's less likely to happen with internal resorption. Usually just it's self-limiting in a way. I made this table as I was trying to think of a best way to kind of make a decision. Now, none of these factors is exclusive of the other. Usually they're all intertwined. The issue is we're trying to determine histological status of a pulp using a clinical exam and a radiographic exam. And that's usually not a great association. The perfect way to do it would be to take the pulp out, put it on a slide, and look at it under a microscope. But unfortunately, we don't have that luxury, and we can't do that. So we're going to use these clinical signs as best as we can. Restorability. If the tooth is non-restorable, you already have your answer. It probably needs to be removed. With pain, I usually ask the parent, is it something where they just eat something and then for a few seconds and then it stops? Or is it something that keeps them up at night, or they hold their whole face for a good 30 minutes after they eat? If it's the latter, it's an extraction. Assessing the pulp. If you accidentally iatrogenically expose it, it's a healthy pulp, or you have some reversible pulpitis, you can get away with a pulpotomy. With irreversible pulpitis, or if you open up that pulp and all you see is necrotic tissue, it's time for an extraction. With gingival tissues, assessing them, if you see a parulus or a fistula, there is a really good indication for extraction. I usually like to check for mobility. If I see the tooth is mobile beyond physiologic means, it generally means there's something going on underneath that needs to be extracted. In terms of percussion test, if I tap on a tooth and the child almost starts crying or jumps out of my chair, that gives me a great indication that it needs to be removed. One way to judge it, if you kind of get into the tooth and you're unsure, is the pulpal hemorrhage. If you take a wet cotton pellet and put it in the pulp chamber for about 3-4 minutes, maybe 5 minutes, and if you've done a really good job at removing all the pulpal tissue and you take that out, you should see 3 orifices that have hemostasis. If you see instead a gushing blood like a hyperemic pulp, that's a great indication to have the tooth removed, because there's probably a great deal of inflammation in the apical portion of that root canal. As far as a radiographic exam, there's not much. This is kind of something you guys all have been trained for. You check the PDL space. If you see any enlargement or a radiolucency, chances are that tooth needs to be removed. One thing to keep in mind with posterior primary teeth, that radiolucency may not be at the apices. It's generally at that furcation, and that's what you're looking for. As far as age of a child, if you have an 8.5-year-old with half the tooth missing already because the new tooth's coming in, you shouldn't be doing a pulpotomy. You should be focusing more towards an extraction. If they're a 6-year-old with a full root on that primary tooth, then you know what? Maybe you should go ahead and try to do a pulpotomy. The general rule is 1/3. If it's less than 1/3, go ahead and do a pulpotomy. If it's more than 1/3, go ahead and do an extraction. And finally, I want to leave you guys with some resources. One of the other questions I got is, how do I do antibiotic dosing or dosing for different things? And the best thing I can give you as a resource is this document, Useful Medications for Oral Conditions. It's from the American Academy of Pediatric Dentistry. It has any oral medication you can think of in there with a proper dosing, and you just have to do the math. I wish there was an easy way to do it. I'd be using it, but it's kind of a nice resource to have. Maybe you can bookmark it. This link will actually take you directly to the PDF. But this little document is actually a part of these other documents from the American Academy of Pediatric Dentistry's Oral Health Policy and Recommendations. These are usually packaged every year in this reference manual that you see up here on the top right. And it's a bunch of policies. If you're interested in any pedo topic, whether it's a sealant or pulpotomy, general anesthesia at the office, there's a lot of resources here that you can read in PDF format and at no cost to you. I've had in past webinars, people ask me, is there a kind of a nice book that summarizes pediatric dentistry? And to me, this is the best book out there for me. It's more of a Cliff's Notes. It has some really great sections if you're really interested in pediatric dentistry. It's called The Handbook of Pediatric Dentistry by the American Academy of Pediatric Dentistry. Again, it is a bit pricey, but I think it's well worth its cost. This is kind of what pediatric dentists use to study for their boards, in addition to that manual that you see up on the top. These links will be hopefully posted in the chat soon. And that brings me to the end of my presentation. I'll take any questions, and if there are none, or we don't get to them, feel free to email me and I'll be happy to respond to you. Thank you.
Awesome, John. Thank you so much for doing that. That was absolutely incredible. As always, a wealth of knowledge. One of the important things that I also want to highlight, just the simplicity of SDF, but yet it's so versatile and it can be used so many different times. So thank you so much for sharing that. I'm just going to go through a couple of housekeeping items before we go ahead and pass the mic on to Katie to go ahead and get started with the Q&A. So please make sure, if you haven't done so already, to place your name, email address in the chat group for CE verification purposes. To sign up for our upcoming lectures, please visit the dtacademy.ca. And for videos, they will be uploaded on the Dentistry Academy YouTube page. So I just want to also be, Dr. Gothsu from Friday, he's opted not to have the video posted for patient confidentiality reasons. So please feel free to email me at drshurgan@amitymanagement.com. And what I'll do is I will have the video for you to view. And that way we can kind of just make sure that we're able to also get it to all of our viewers as well. Just as another reminder as well, to follow us on Instagram and or LinkedIn to receive all of the latest information and updates regarding our upcoming talks. Tomorrow, Tuesday, May 12th at 11 a.m., we have Ben Mueller, who will be talking to us about the balancing treatment needs with patient individuality, along with Mr. Christian Hall, who will be talking to us about the CBCT treatment planning aspect of things. So please register at dtacademy.ca. And just as always, the password is TRACK, all caps, 20. So I'll go ahead and pass the mic on to Katie for the Q&A aspect.
Hi, Dr. Mansour. That was an excellent presentation. You have quite a few questions, so I'll try to get through all of them if I can.
Sure.
So the first question, there's two people who kind of asked the same question. So it was relating to the rubber dam from Mohammed and Alice. So they've asked, do you always give IA and B block when treating mandibular teeth? If not, how do you place the clamp without hurting the child?
Very good question. I think local anesthesia is a very good thing to do if you're placing a clamp. It stimulates the child. Do I always use an IAMB? No, I do some infiltrations depending on what I'm doing. So for example, if I need profound anesthesia and a tooth is abscessed and I'm going to be removing it in addition to doing another tooth in that quadrant, let's pretend 8-4 is abscessed, 8-5 needs a stainless steel crown, I will go ahead and do an IAMB in that situation. However, if it's just restorations, I typically default to just local infiltration. And generally when I do that, I am able to place a clamp on very comfortably for the child. Now, there are plastic clamps that are sterilizable, but they don't last as long, which are technically a little bit more, it creates a little bit less pressure to hold on to the tooth. In my hands, what I've found is after about 10 sterilization cycles, they don't hang on as tightly and they don't give me the security that I need, but they are a bit more comfortable. So if you have one of those plastic clamps, I would say maybe you can even, I've heard of people placing it with only topical, but generally if you are using a metal clamp, you should probably be giving local anesthesia.
And then Hina has asked, what are some of your favorite clamps to use?
Great question. For me, it's I like the 12 and the 13 clamp. The reason for that is it's basically per quadrant. you can adapt it to the tooth a lot better than a general clamp like an 8A. If you want one clamp, an 8 or an 8A is a great option. I know some people that use the B2 or the B3 clamps. Those don't have wings, so what you would be doing is you'd actually be placing the clamp first and then the rubber dam after. But if you're trying to place it all as one contraption, generally you need something with wings. There's a variety of different clamps. It's really what works well in your hands, and I would advise you to whether get a sample of a clamp just so you can see how it holds in a mouth, and maybe try it on an adult first just to see, I know some of these are smaller clamps, but maybe like a premolar so you get comfortable with it.
Great. And then this next question is from Kate. So she says that you did a great presentation. She thanks you for it. And then she says, what are some of the possible risks of GA that you would think would be worth telling the patient before referring to a pediatric dentist?
Very good thing. I would say usually pediatric dentists are very well versed in how they present this to them. You don't want to scare off the parent, but some parents already come in with that, what if my child dies? The risk is very, very low. And what I like to tell them is the numbers, this was from a few years back when I was studying for my board. The numbers said that there's a 1 in 300,000 chance that there could be a fatality with general anesthesia. With driving a car, there's 1 in 65,000 chance. Having said that, it's 5 times safer than driving a car, yet we drive a car every day. Obviously, they need to be assessed by an anesthesiologist who can make a proper assessment that they're healthy. And if they're a healthy child over the age of 3, the risk is very, very low. And if anybody tells them that the risk is non-existent, or there's no risk, they're obviously being lied to. But you always want to have that conversation because these parents need to know. And I've had some parents that said, you know what? The risk of my child dying, no matter how little, if my child is the one, is not worth it. And you can usually leave that to the specialist to kind of walk them through. But generally speaking, it's a very low risk. You don't have to worry about it too much. And now that we're getting a little bit more research on the learning disability type of thing and the effects of a general anesthesia on the developing brain, that's more favorable, you can probably be more confident in your referral. However, like I said, I've had plenty of parents come in, they'd rather do nitrous and they don't want anything else, or silverdent, and we do have other options there.
Okay, great. This next question is from Pio. He says, great presentation, John. Just a quick question. What code would you put through when administering SDF?
Great question. So SDF does not really have a specific code at this time in Canada. The code that most people are using is 13601. It's an antimicrobial code. It's per unit of time, unfortunately, not per tooth. Also, in terms of other codes, you can use a fluoride code if you want to. There's also another code, I believe, I can't remember off the top of my head, but those are the 2 main codes. One thing to keep in mind, 13601 is usually not covered by insurance, so you have to be very upfront with the patient. If you are billing it, usually when I do it along with a fluoride treatment as a part of a recall, I just bill it out as one package. But if I'm doing it separately, then we have to kind of either bill it out as a fluoride or bill it out as a 13601. To the best of my knowledge, the Canadian Academy of Pediatric Dentistry and the CDA are actively working on a better code, but obviously with COVID going around, they have other things on their plate right now.
Okay. This question was asked privately, and it's asking, at what point would you in the child's behavior management, is it appropriate to refer to the pediatric dentist as opposed to trying again?
Very good question. That really depends on you and how comfortable you are with children. Let's say the child comes in and they're just having a down day from the get-go, and it's not like you saw them at the console and they were extremely happy. Now they're not. It's like a whole different child. And sometimes talking to the parent outside of the operatory is what gives it away. Hey, did they have a tough day today? Yeah, you know what? They went to school and they had a really rough day. Then you know what? Maybe we should try again. Or if it's something that, where we're going to do one thing and you're now switching to another and it's a little more traumatic, you can always feel free at any point where you're comfortable to refer out. But generally speaking, if you've had a previous favorable experience and now the child's not doing too well, go ahead and try again. Maybe it's just a day. But if right off the get-go, the child's not very happy, you can rest assured probably a good idea to just refer out.
Okay. This next question is from Dean. She says, hi, John, are you familiar with the SDF called Rivastar from SDI? If so, how does it compare with the one from Oral Science?
Great. So Rivastar is great. They market it as a non-staining SDF, basically. It doesn't stain, and then supposedly you can build up upon it with glass ionomer so it doesn't stain. What I found is that, yes, initially the first 6 months, it may not stain, but eventually you start getting this brown color. If you are going to want more resources on that, I highly recommend a Jeanette McLean Bud lecture. There's quite a few of those. I know Viva Learning may have one of those, and for free. And then Dental Town, she has a couple on. And like I said, she was supposed to come to the ASM. She's a great resource for these questions. I would defer to her. But Rivastar, I've tried it a couple of times, and honestly, both times it was cosmetically demanding patients who had actually looked it up. And I warned them that it's going to stain brown. And sure enough, 3-4 months later, when they came back with a recall, it was initially okay. It's supposed to precipitate all those ions so it doesn't turn black, but in my hands, it actually turned brown.
Okay. This next question is from Stephanie, and she asks, do you ever do pulpectomies on necrotic primary teeth instead of extractions?
Yes, I do. It depends on the child and the situation. So if it's in the chair and the child's pretty cooperative, and I'm trying to save an 8-5 where the 4-6 is not in yet, or similar situation in another quadrant, I'm trying to just hold on to this tooth until the 6-year molar comes in, where if it abscesses after that point, I can easily do a space maintainer. That's when I would do it. And I've had pretty decent success with pulpectomies. But one thing I will say about pulpectomies in children's teeth, it's not as straightforward as a permanent tooth, mainly because the canal is an intricacy of multiple canals, and you're relying more on your chemical debridement rather than your filing and mechanical debridement. And there is a decent failure rate with those. So usually if you're doing it, you have to be pretty sure the child can sit in the chair again for an extraction. And other times I've done it is on anterior teeth where parents really wanted to save them. Again, mixed results in both of those.
Okay, so we have a couple more questions left. The next one is from Kane, and they asked, how would you decide between temporary restoration, GIC, temporization, and SDF?
Very good question. Typically, I like to defer to SDF first, and because to me that generally works really well, and I can always place the GIC later. However, if I have a parent that's absolutely anti-SDF, is okay with a GIC, I tend to go with a GIC in that situation. It really depends. I've used a mixture of both for some parents. I've had parents that didn't want it on the front teeth, and I've used a GIC there until the child's older, and for the back teeth we use SDF. So it's really just feeling out the patient and trying to find what's the best solution for that patient.
Okay, and then we have the last question from Nadia. She says, thanks, Dr. Mansour, for the wonderful presentation. And can stainless steel crown be placed after SDF without placing a restoration?
Yes, you absolutely can do that. It's a great way and to do it. Like I was saying, when I go to the OR sometimes, where I go ahead and prepping something where I saw this patient 6 months ago and I'm thinking, oh yeah, this is a pulp now. Nope. Just prep it, go ahead and place the SDF. If you feel like it's a little deeper than you're comfortable with, you can always put a liner if you want to. But generally speaking, when we're cementing stainless steel crowns, they do have a glass ionomer cement. So that does fill in those areas as well.
Okay. And that seems to be all the questions that we have today. So awesome. I'll give it back to Dr. Hisham.
Thank you so much for that, Katie. Wonderful job. John, as always, thank you so much for that. If you have any additional questions, please feel free to go ahead and just ask them on the chat line. John is very active on the chat line, and we can always pass those on to him. So I'm going to go ahead and pass the mic on to Dr. Azim Sheikh to introduce our next speaker.